Good afternoon. Welcome to this session titled The Key to Key Populations. I'm Brenda Hoagland, co-chair of this session. I'm MD, PhD in clinical research of infectious disease from Oswaldo Cruz Foundation in Brazil. There I design and conduct prevention studies in HIV. I would like to ask Dr. Ives Wamp, the co-chair session, to introduce himself.
Thank you, Brenda, but I'm not a doctor. I'm Yves Yom from Cameroon. I'm the coordinator of a network called Africa Gay Contre le Sida.
Today, we will have presentations of 6 speakers from different parts of the world, including Europe, North America, Africa, Asia, and Australia. They will focus their presentations on 4 key populations, including MSM, migrants, female sex workers, and injectable drug users. Some rules.
Yeah, maybe before we move to the first presentation, I would like to remind some rules of the session. We will first listen to all the presentation, and after that we will have the Q&A session with the audience. Every speaker will have 10 minutes to present, and if we respect this time, we will have 30 minutes for the question.
I have the honor to introduce our first speaker, Dr. Julia Delano from Spain. She is tenured professor of research in biomedical science in the National Center for Epidemiology, Institute of Health Carlos III in Madrid, Spain. She has a solid track in researching inequalities in HIV infection, with a particular interest in inequalities by race, ethnicity, and migrant status. She has contributed to the understanding of HIV disease progression in migrants, minorities, and women, and to estimate the burden of disease of HIV in migrant populations in the European epidemiological data and their HIV testing patterns. Her postdoctoral experience is in research dates from 1998. She started her research career in London in 1994. In 2006, established her own research group in the National Center for Epidemiology after obtaining tenure by the National Board of Scientists in 2005. Doctor.
Thank you very much for that extensive presentation.
Okay.
Good afternoon, everybody, and thank you again for choosing this work that I'm presenting on behalf of Deborah, who is the first author of this presentation and is the person who's been leading the work. I'd like to acknowledge that AMAZE is a European collaboration. Many of the co-authors of this work are here this afternoon, and I want to acknowledge the contribution, particularly that of Jota Tolumi and the Greek team who led the statistical analysis. These are my conflicts of interest, and I will be addressing this objective. We aim to estimate the proportion of post-migration HIV acquisition among HIV-positive migrants in Spain. We conducted this multi-center cross-sectional study, which, as I said, was part of a larger collaborative project that has been published in AIDS only 2 or 3 weeks ago. And the study consisted in administering 2 electronic questionnaires. One was patient's questionnaire, which we administered through iPads or PCs that had extensive data on migration, sexual history, and other HIV risk behaviors. It was largely self-administered. I say largely because for some migrant groups, it required some assistance in order to fill in the questionnaire. It was approximately 20 minutes duration, but it had lots of branching to save time and address as many data as possible. It was closed questions. We had built this based previously on extensive qualitative methodology. We translated it to 14 languages to address most migrant groups at risk in Europe. Consent was given by the patient electronically, and we had both online and offline solutions to ease its administration. As well as these extensive patients' reported data, we collected data from the clinical notes, which was filled in by the researcher, again, online and offline solution, and here we had documentation of previous HIV negative tests, testing patterns, CD4 cell counts, etc. I'm presenting the data from just Spain, and these are the 17 sites which contributed to the European data from Spain. The characteristics and the participant inclusion criteria were as follows: migrants defined as anybody who had been born in a country different to the one he or she was residing in, which had been diagnosed with HIV in the preceding 5 years and who was living in Spain for at least 6 months. And this window of selecting people with diagnosis in the previous 5 years was aimed to minimize recall bias, because we wanted people to tell us lots of things about their sexual life and sexual activity that needed a gap of time. So, as I said, questionnaire was extensive, lots of branching, and we collected all these epidemiological, socioeconomic, clinical, migratory trajectory, data on previous tests, CD4 cell count, viral load. It was very data consuming, very data demanding, because we needed all this information to assign a probability of HIV infection before or after migration. The statistical methods to estimate post-migration HIV acquisition were very complex, and here again I want to acknowledge the Greek team led by Jota Doloumi, who designed this Bayesian approach that combined all this information we had collected on migration, risk factors and behaviors, and CD4 cell count. And to make this very complex statistical model simple, let's put this example where an HIV-positive migrant gets diagnosed with HIV in June 2013 with a high CD4 cell count. If we have information regarding the arrival to Spain 7 years before, this is the kind of person that is likely to have been infected with HIV after migration. So, based on CD4 cell count and viral load trajectories, which were modeled through mixed models based on the cascade collaboration of seroconverters, we could trace the individual probability of becoming infected before or after migration, combining, as I said, the information on viral load, CD4 cell count, sexual history, risk behavior before and after migration, etc. These detailed statistical methods are being submitted to a statistical journal led by the Greek team and are ready for those willing to know more about Bayes' theorem and its application to practical public health problems. Overall, we have 710 participants, of which we had data to estimate HIV acquisition on 685 of them. 77% were men, 60% were men who have sex with men, with lower number of heterosexual women, 20%, and 14% of heterosexual men. Median age was 35 years, and the median time they had been in Spain was 9 years as median time. Contrary to other European countries, the majority of the migrants in our study came from Latin America and the Caribbean, and this is consistent with the migration patterns in the general population in Spain. Only 13% of migrants living with HIV in AMAZE came from sub-Saharan Africa, and this was quite unique of Spain compared to what was happening in Belgium, Amsterdam, or the UK. Overall, the estimated post-migration HIV acquisition probability in the study in Spain was as high as 72%. 72% of the migrants in our study were infected post-migration. And this was particularly high for migrants from Latin America and the Caribbean, 75%. You can see migrants from sub-Saharan Africa, the post-migration HIV acquisition was 59%, similar to, a little bit higher, but similar to the results presented by Annabelle Decret in the Parcours study. And when we looked at what happened by transmission category, it's men who have sex with men who have the highest probability of becoming HIV infected after migrating to Spain. When we looked into the risk factors associated with post-migration HIV acquisition in the multivariate analysis, the length of stay in the country, as expected, was a risk factor for becoming infected with HIV in that country. The longer you stay, the higher chance is becoming HIV positive. And the year of diagnosis, this phenomenon is more common in recent years, with a borderline increased risk in men who have sex with men, which I would say that even if it doesn't fulfill the criteria of statistical significance, is twice as common. So to conclude, 7 out of 10 migrants living with HIV in Spain acquired HIV after migration. The proportion of post-migration HIV acquisition is higher among men who have sex with men and in people from Latin America and the Caribbean. The risk of post-migration HIV acquisition increases with time and is more common in recent periods. And what these results show is failure in preventive interventions in specific migrant groups. We need to design interventions to prevent HIV infection in migrants, accounting for the heterogeneity of the migrant population, acknowledge the increase of men who have sex with men of migrant origin who are becoming infected with HIV in Spain, as in other parts of Europe, and obviously this will require PrEP, which is still not available in Spain, and which we hope after this conference there'll be renewed energy for that. I want to acknowledge the funders, the institutions, particularly Eurocode and the AMAZE study, which I said was funded within this Eurocode, and all the participating clinics contributing to this in Spain. Thank you very much.
I would like to introduce our next speaker, Ms. Perrin, she's doctor in pharmacy from Bordeaux, France, and master in public health from University of Paris. And she's researcher in INSERM from Marseille.
Thank you.
Sorry.
Thank you. It's okay.
French is
it's
not
perfect.
Okay.
Good afternoon, everybody. I'm very pleased to be here, and I would like to thank the organizer to give me the opportunity to present our results. I'm going to talk about an emerging key population, which is represented by men who have sex with men and who practice chemsex. And more specifically, this study aims at investigating whether on-demand PrEP could be a suitable tool for men who have sex with men and who practice chemsex. We used the results from a sub-study of the ANRS Hypergay trial to answer this question, and I would like also to thank my co-authors that participated in this analysis. So first, I have no conflict of interest to declare. So what is chemsex? Chemsex is the use of psychoactive substances during sexual encounters, and as you probably know, this is a growing concern among MSM. The main reasons that are reported by MSM for practicing chemsex are not only to increase confidence, disinhibition, and stamina, but also to enhance sexual arousal and eroticism, and to seek new sexual experiences. In addition, the main drugs involved in chemsex practice are crystal methamphetamine, GHB, GBL, and synthetic catinone. All these drugs are psychostimulants. Some of them are empathogens or hallucinogens, and they have all a high potential of addiction. There is also a very risky element in chemsex practice, which is called slam or slamming, and which is defined as the injection of a drug before sex. All these chemsex practices have many negative consequences, and it could be either related to drug use or to sexual risk behaviors. And of course, it includes HIV transmission, among other infectious consequences. 2 years ago, the ANRS Hypergate trial showed that on-demand PrEP is efficacious in preventing HIV transmission among MSM. And today we would like to answer the question, could be PrEP a suitable tool for preventing HIV transmission among this key population, which are the chemsexers? So we used the data from the ANRS Hypergate trial, which is a double-blind randomized trial that has been conducted in France and is in Canada, and it provided sexual activity-based PrEP. The inclusion criteria were being HIV negative male or transgender female having sex with men, and of course being at high risk of HIV acquisition. We collected data from online questionnaire every two months, which gathered data, sociodemographic data, drug and alcohol use, sexual behaviors, PrEP adherence. This was during the most recent sexual encounter. This present study was the open label extension phase of the trial, and it focused on 331 participants, accounting for 1,657 visits. The median follow-up duration was 10 months, and the main objectives of this sub-study were first to characterize chemsexers, which was defined as being under the effect of a psychoactive drug during most recent sexual encounter, and secondly, to study the association between chemsex and PrEP use, and which was defined as having used PrEP during most recent sexual encounter. We used as a statistical analysis a logistic regression based on a GEE model. So the first results was a descriptive result of the population, and we found that 29% of the participants reported having practiced chemsex during follow-up, at least once during follow-up. When we compared chemsexers versus non-chemsexers, we found that chemsexers were more likely to use anxiolytic, were more likely to have higher sensation-seeking score, and to report higher number of sexual encounters, and of course, to practice slamming. We also studied the factors associated with chemsex at most recent encounter, and we used all the visits. We found that in 16% of visits, chemsex was reported. It was mainly with one partner, but it could be also with multiple partners for 1/4 of the visits. The main drugs that, psychoactive drugs that were involved in chemsex practice were GHB, GBL, and synthetic catinone, but also amphetamine-like substances and cocaine. When we compared chemsex, we studied the factors associated with chemsex. We found that the type of partner, casual partner or multiple partner, was associated with chemsex practice. High-risk HIV exposure, which was defined as condomless anal sex. hardcore sexual practices, HIV transmission risk perception, and also PrEP use. And we confirm the association between chemsex practice and PrEP use after adjustment for potential confounders, such as education, age, recent depression, the type of partners, and these results show that at a given visit, individuals who reported chemsex practices were twice more likely to use PrEP. So as a conclusion, our results show that chemsex practice is associated with PrEP use. In addition, an interesting result is that there is no significant difference between chemsexers and non-chemsexers in terms of socio-demographic profile. However, chemsexers have a more vulnerable psychological profile in terms of anxiolytic consumption and higher score of sensation-seeking scale. And also, chemsex was associated with high-risk practices, with sex parties, casual partners, hardcore practices. It is also associated with a higher HIV risk perception. And our findings show that PrEP could be a suitable harm reduction tool for people who practice chemsex. In addition, access to PrEP could be a good opportunity to provide other prevention interventions and comprehensive care for chemsexers. And I would like to thank all the participants of the study, all the members of committees, the researchers, and the funders. And I would like to thank you for your attention.
So our next speaker comes from the US. His name is Dr. SWAT. I think I pronounced this well. She is an HIV epidemiologist whose research focuses on services optimization for women at high risk for HIV infection or women living with HIV, including female sex workers, pregnant women, adolescent girls, young women, and women in serodiscordant relationship in sub-Saharan Africa. She will present us her work titled Assessing HIV Prevalence in Health Outcome of Children of Female Sex Workers in Port Elizabeth in South Africa to guide PMTCT programming for vulnerable population.
Thank you to the organizers for the opportunity to share this data on behalf of my co-authors at Johns Hopkins University, at the TB HIV Care Association, and the Human Sciences Research Council. Globally, we know that a disproportionate number of female sex workers are living with HIV. This is also true in South Africa, where national estimates of HIV prevalence amongst female sex workers are 60%. The data presented on this slide come from Port Elizabeth, South Africa, where the current study is also placed. And these were data previously collected by our group using respondent-driven sampling. There we found, similar to national estimates, that 63% of sex workers were living with HIV. And here you can see on this cascade that overall we had high rates of prior diagnosis and knowledge of HIV status amongst the female sex workers, but only 39% of female sex workers in this area were on ARVs. Unfortunately, we didn't have viral suppression data for everyone, but amongst the pregnant women living with HIV, who we were able to get viral suppression data for, none of them were virally suppressed. So of course this leads us to wonder and consider what the vertical transmission risks are in this group. We know from many studies that have been published that the majority of female sex workers are mothers. And although this isn't, when you think about it, this isn't really anything groundbreaking or outside of what you would expect, commonly, we actually don't think about sex workers as being mothers. We often think about them based on their occupation and forget that they have rich, diverse lives outside of their occupation, which often include families. And very little is known about the children of female sex workers. Few data are available about their health outcomes. Thus, the objective of this study was to directly assess health outcomes, including HIV prevalence among children of female sex workers, to characterize the dynamics around sex work and motherhood, and to identify programmatic needs for female sex worker mothers and their children. This was a cross-sectional study conducted in Port Elizabeth, South Africa, in which we recruited mothers at sex work venues that were served by mobile van health services. Mothers were invited to bring their children into a different study site. They were eligible if they were 18 years and above, engaged in sex work as a primary source of income in the past 12 months, and if they had one or more children that were 12 years of age or younger that they could bring to the study site. In terms of data collection, we conducted questionnaires with mothers in which we asked them questions about the health of themselves and their children. We abstracted data from their medical records and administered HIV testing. For the children, we just did a health assessment. We did HIV testing for all of the children using PCR if the children were known to be HIV exposed and under 18 months, and rapid tests for children above 18 months. We also measured their height and their weight and abstracted data from Road to Health clinic cards. And these are cards in South Africa that include data on vaccine coverage, engagement in healthcare, and several other health characteristics. In terms of the characteristics of our sample, 114 mothers and 200 of their children were enrolled. The average age amongst mothers was 32 years. Women had on average 2 children. Amongst the children attending, the average age was 6 years, and the majority of them lived with their mothers. In terms of the mother's health, we saw that 68% of the mothers were living with HIV, and ART coverage amongst these mothers was around 64%. I just want to compare this to the data that I previously presented from our RDS study before, in which we saw similarly high rates of HIV prevalence, but much lower engagement in ART care amongst those women. In terms of data on pregnancy and sex work, we saw that on average, women engaged in sex work for 5 months of their last pregnancy, and by 6 months postpartum, about half of them had returned to sex work. Most of the children stayed with their mother, and amongst the children that weren't staying with their mother, they stayed close by. They were on average less than an hour away. In terms of determinants and proxies of children's health status, we found that 73% of the children attending the study had been breastfed for an average of 6 months. 54% of them had been previously tested for HIV, and about half of them had been tested post-cessation of breastfeeding. In terms of HIV prevalence amongst the children, we found that 3% of the children were living with HIV. Amongst the children with HIV-positive moms, this was 4.5%. And so overall, amongst the 114 mothers attending and participating in the study, 5% of them had a child that they brought to the study that was living with HIV, and 8% of the HIV-positive moms brought a child living with HIV to the study. In terms of stunting and wasting, and these are assessed for using height for age and weight for age, and are indicators of, respectively, chronic malnutrition and more acute food insecurity. We saw that 27% of the children were stunted and about 12% were wasted. We also looked at vaccine coverage, and this graph shows in blue the national estimates in South Africa, and in orange the study estimates amongst the children that had Road to Health cards brought to the study. And here you see that for DTP1 and measles, which are administered earlier in life, pretty comparable coverage between national estimates and steady estimates, but by 18 months of life, when DTP3 and the second measles vaccine are administered, you start seeing some greater gaps in terms of the coverage nationally and in our study. So one of the key limitations of these data are that we know that we're missing moms and missing children. We recruited from a venue that was receiving mobile healthcare services, and so we do believe that the moms and the kids that we enrolled in the study are actually more likely to be engaged in care. So this would lead us to believe that, in fact, our estimates are probably on the lower side in terms of vertical transmission risks in this study. The data was also cross-sectional, and so it's difficult for us to tease out when the mothers were infected with HIV in relation to their pregnancies. And again, I think this causes us to underestimate risk of vertical transmission in this population. And yet still we saw rates, levels of prevalence that were slightly higher than the national averages, about 25% above. The sample size of the study was small, with only 200 children, and yet I do think it's important because this is some of the first data that we're seeing about the health outcomes of these children, and hopefully an impetus for us to start thinking about them more and collecting more data in this population. So to close, we know that the relationship between sex work and motherhood is complicated. People have often suggested that sex workers frequently stay away from their children, and in fact, what we see in this data is that most of these moms at least had good access to their children, and if we can reach the mothers with services, we can also potentially reach their children. There's a need to increase HIV testing coverage among children of female sex workers and address the vertical transmission risks. Increasingly, we're seeing that sex workers are being met with differentiated care programs, although often the focus of these at the moment is on HIV prevention amongst female sex workers. And while this is absolutely critical, I think we need to start thinking about how we can expand these services to include prevention of mother-to-child transmission of HIV, treatment for mothers, potentially HIV testing for children, vaccine catch-up for children, and nutritional education and support. I want to thank our study participants and our community advisory board, as well as our donors.
I would like to invite our next Dr. Phan from Vietnam. He is MD, PhD, is teacher and researcher at the Faculty of Public Health and Haiphong, University of Medicine and Pharmacy from 2008. His main teaching and research topics related to epidemiology of HIV, hepatitis B and C among workers and drug users.
Thank you very much, Chair, and bonjour tout le monde. On behalf of our DRIVE study group, I'm delighted to present our result of the first phase of DRIVE project. This is a project in collaboration between teams from Vietnam, including CBO, community-based organizations, and New York, Paris, also from Montpellier, where they say most beautiful region of France, by our colleague. In Vietnam, HIV control programs targeting persons who inject drugs, including harm reduction, ART, have been implemented for about 10 years. Although the prevalence of HIV is declining, the impact of these programs on the HIV new infection, but also HCV transmission remain unknown. The objectives of our work are to estimate the HIV and HCV prevalence and incidence among active people who inject drugs in Hải Phòng, Vietnam, and also to identify the determinants of HCV seroconversion among this main group. So we carry out a community-based respondent-driven sampling survey among active people who inject drugs in Hải Phòng with HIV and HCV testing. We start implementing the this group study since October 2014. We meant by active people who inject drugs, drug users who have a positive urine test for heroin and presence of injection marks. HIV negative participant and HCV negative participant who were not on methadone maintenance therapy were then eligible for 1 year follow-up. And HIV, HCV serology were tested by 6 months and 1 year of the follow-up, along with routine harm reduction activities and support to access MMT HIV care by community-based organizations. And we then estimated the HIV and HCV incidence, and we also identified the risk factors associated with HCV seroconversion. Among 603 RDS participants, we found that the HIV prevalence was 25% and HCV prevalence was 66%. 250 participants were then included in the longitudinal follow-up. Among of them, 204 were enrolled in the cohort study assessing for HIV and HCV incidence, including 105 HIV negative, HCV positive, 94 HIV and HCV negative, and 5 HIV positive, HCV negative. The characteristics of the cohort, participant in the cohort, HIV negative cohort and HCV negative cohort are presented in this table. Overall, the participants are have similar patterns with the median age of 37 years. They inject for 5 to 6 years and 2 times a day. About a quarter of these people smoked methamphetamine during the last 3 months. They report, very few of them report needle and syringe sharing practices during the course of from the baseline, and also risky, very few report risky sexual behavior. 159 of these 204 follow-up participants remain up to the end of the follow-up, giving a retention rate of 78%, which is high compared to other studies we found before in this population. And we found that no HIV seroconversion during this 206 person years follow-up, giving estimated HIV incidence ranging from 0 to 1.8 per 100 person years. However, we found 18 participants seroconverted for HCV, giving an estimated HCV incidence of 19.4 per 100 person years. Interestingly, 13 of these 18th HCV seroconversion happened during the first 8 months. So that the incidence of HCV was 26.7 during the first 6 months and only 13.2 per person years between the week 32 and week 64. In univariable analysis, we found 2 factors associated with HCV seroconversion. The first one is the number of injections per month, and have been arrested at least once during the course of follow-up. But in multivariable analysis, we found only the number of injections as the participant who inject more than 73 times per month have higher risk of HCV seroconversion. The OR ratio was high with 13.7. Interestingly, being arrested during the course of follow-up were positively associated with HCV seroconversion, but this did not remain significant at when we in the multivariable analysis. So to conclude, although our finding should be confirmed with more data, the HIV incidence was very low, remarkably low among active people who inject drugs in Haiphong. And this likely results from the high coverage of harm reduction activities, including MMT and ART in Haiphong. In contrast, the HCV incidence is unacceptably high. So more investigation need to be done to answer why. And however, as in other settings, it is unlikely that harm reduction activities alone, even adapted for HCV infection, will be able to control the HCV in this group. Therefore, large access to HCV treatment is now a priority given the efficacy and safety of DAA. Further implementation studies are required to define an appropriate model of HCV testing and cure among people who inject drugs in Vietnam. Finally, we would like to thank our funders, the INS, NIDA, Global Fund, for funding our project. We would like also to thank the Haiphong Provincial Health Authorities, Việt Tiệp Hospital, for their support and their participation. We take this chance to thank Dr. Vũ Văn Công, Professor Trương Thị Xuân Liên, who's present here also, and Professor François Barré-Sounousi. We thank the DRIVE Scientific Advisory Board, and especially Laurence Wade, Jean-Pierre Delouet, who are here today, and we would like to thank all participants enrolled in this study. Thank you.
Thanks very much to all the speakers for the wonderful presentation. We can now open the Q&A session with the audience. We have approximately 20 minutes for that. We have 6 microphones in the room. I just want to remind you to introduce yourself because before addressing your question to one or more speaker.
Hello, I'm Hian from Hanoi University of Public Health, and I have one question for the presentation on chemsex. So, do you have any information about the multiple partner, chemex among multiple partners, and also crystal methamphetamine in particular? Thank you.
Thank you for your question. So regarding multiple partners, we found that among all the visits where chemsex was reported, it was about 1/4 of visit where it was multiple partners. So it's mainly just with one partner, but yes, this is the situation in this trial. Regarding methamphetamine, it's not the main drug that is used in France. It's not very available. It's a growing concern, but not as much as in other countries. So it's mainly synthetic cathinone and GHB.
Vincent, in France. Still regarding chemsex, sir, do you have data to know if participants were involved in chemsex before they were enrolled in the trial?
We did not study that data. I'm not sure that, no, I think we don't have that data, sorry.
Hi, good afternoon. My name is Martin Chu. I'm from Kuala Lumpur Aid Support Services Society in Malaysia. This question is directed to Nathan or Andrew or anybody in the panel. In particular, I want to ask whether, concerning gay men or MSM who use substances, whether in your study you've seen, whether you can comment on the social networks of these men, whether they interrelate with men who don't use substances.
We don't have social network data within our study. Some folks have used respondent-driven sampling chains to try and look at those kinds of networks, but we're not able to distinguish whether the recruiters within those chains are necessarily the people they're reporting sexual behaviors with. I think in terms of substance use, when we just look at the reported data, what we do find are that there are a number of sexual events where substance use is not reported, and some that there are. So there's certainly heterogeneity in that regard.
Sheena McCormack from London. I wanted to ask, is it Dr. Min Ku Pham, about your project, because there were quite a lot of people who didn't enrol, and then when you were talking about the loss later on, a high proportion had been imprisoned, and I wondered if you had a chance to interact in any way with the prisons to see if you had the opportunity to find any of your lost to follow up in prison, because I think what was really remarkable to me was how little HIV transmission there was. I find that really difficult to believe, and do you know what I mean? It's hard to think those individuals you lost were going somewhere else and getting on treatment.
Thank you for your question. Our colleague from the project are here too, but firstly, I would like to say that our retention rate, 78%, is something that we found high compared to other study assessing for incidents. Mostly another study in Hanoi, Vietnam, in 2005, the retention rate was about 40-something%, I don't remember exactly. But really in our study we have about 22 people who were arrested, so that the largest number among the lost to follow-up. And unfortunately we didn't have a chance to follow them or to have more detail in the prison. Many people in Vietnam discuss also how we can care people in prison, but from what I know, we don't have much information for that.
Yes, I'm sorry, I think I didn't probably phrase my question very well.
Yeah.
Your retention in those that were enrolled, you know, as you say, I think for that cohort was pretty high.
Yeah.
But there was a shockingly large number who did not come back for their results. I think that's what I was... And then I was thinking, well, if they didn't come back for their results, how did they ever get on treatment? And why wasn't there a lot of HIV transmission as well? I think that's what I was puzzled by.
Yes.
But don't worry. Yeah. So sorry.
I don't have answer at the moment.
Back. Thank you. Good afternoon, one and all present here. I'm Dr. Marina Leone, and I'm from the Doctors of the World Headquarters, Paris. My question is to the gentleman from Vietnam. Knowing that previously, this is again from the public health side now, knowing that in Vietnam previously only 30% of all the costs for the general population as far as pegylated interferon for HCV treatment was covered for a person belonging to the general population, with people who inject drugs not being considered anyways. As far as DAAs are concerned, are there any positive lookouts in your view as of now?
Yeah, that is our big question for this moment, because DAA is now included in the guideline for CV treatment in our country. But given the high price, and we are looking for opportunity to see how we can treat these patients, at least mostly in the very vulnerable population like the drug users in Vietnam. Even in our study, we have around 30 CBO members, and 10 to 15 among them are also HCV infected, and they are sick. And in this room, Dr. Didier Loya, he's infectious doctor, and he worked like a clinical coordinator of DRIVE, and he very forced to search for drugs for these participants, and really we are looking for the way to be able to treat this patient.
Thank you.
Hi, I'm Ashley Grosso from Public Health Solutions in New York, and I have two questions. First, for the study with migrants, did you consider whether they may have acquired HIV during a visit outside to their home country? And for the chemsex study, how reliable do you think the self-reported PrEP taking was, given that they were under the influence? Did you use any biomarkers or counting pills or any other method to verify?
Thank you for your question. And in fact, this is the kind of thing we're not totally sure. This is why we phrase it as HIV post-migration acquisition. It could well be that these men are traveling back home in what is called circular migrations, or are visiting other countries outside Spain. What we want to highlight here is that once these migrants come to Spanish territory, it's our responsibility as public health institutions to make sure they do not become HIV positive, whether that's in a gay bar in Madrid or whether it's in a visit in Mexico DF. But it's very difficult to pinpoint exactly where they got infected. This is why we frame it as HIV post-infection acquisition. Thank you for your question.
Regarding the self-reported PrEP use, yes, we think that, of course, it should have an underreported PrEP use in people who are under the effect of drugs. We don't know if the data are reliable. However, we have quite good adherence in those who have complete data, because we have many missing data. That's why we decided to to use only the question, the general question regarding PrEP use in general.
Hi everybody, my name is Maxime and I'm from International Committee on the Right of Sex Worker in Europe, and I have two questions also, if it's possible. The first is for Julia Delano. I would like to know if you have more information or data about specific migrant sex worker, and if they are carrying HIV with the sex work in Spain or not. That's my first question. And after it's for Dr. Schwartz, I think it's that. Excuse me. And female sex worker in South Africa. Just I would like to know if you have more information or data for male and trans sex worker and the question of HIV in South Africa.
Thank you for your question. I thought we were going to be asked these questions, but we have not had time to look at those data, but we are going to look into that because, as you well point out, is one of the main risk factors that we may be encountering in these men. And as you probably know very well, the prevalence of HIV in male sex workers and in trans women is very high in Spain. There are not a lot of data, but it's very high, and they are in very vulnerable situation. But this is one of the things we are looking into, and we've had no time for this meeting. Thank you.
Say from South Africa. Our group has not collected any data with male sex workers and trans women in Port Elizabeth or in South Africa. I know that there are some data that exist, and prevalence is quite high. In terms of HCV, I don't know of HCV data with male sex workers in South Africa. I do believe that there's some studies going on with people who inject drugs in South Africa, and there may be some overlap there. But
the last question.
Yes, hi, Chris Archibald from Canada. I have a question for Dr. Grulich. A very interesting study. And I want to ask how about your assignment of the couple of years of follow-up, and were all of the periods of time mutually exclusive with your categories? Because I think I was a bit confused with some of the assignment of categories when you're having receptive or insertive sex.
So in that analysis, they were assigned to the higher risk behaviour. So if you had both insertive and receptive sex, they were assigned to the receptive category that it occurred in, and not the insertive.
Okay, I would like to thank the audience and all the speakers and all the important results that bring to us today, and have a great afternoon and congress.